It's interesting to me that last legislative session, FamilyCare was frustrated with this process, and one of the things they advanced was a bill that would have had the Department of Consumer and Business Services be the agency that would review the rate setting process that's done by OHA. At the time that they proposed that bill, that would have meant that Laura and I would have been the people doing the review of the rate setting process. And so it's kind of interesting in that context to think of us coming in on September 1st on the day that rates were to be reviewed or released, pushing pause for a week so that we could do a cursory review of that process and see if we could identify problems. Taking the added step of bringing in outside analysis to look at the methodology. And at each step of the way, we've come to the general conclusion that this rate setting process follows the law, has been applied fairly, and follows accepted actuarial principles. I think that's a different question than is it the only way that you can do rates that meets those standards, or is it the best way to do rates that provides for a sustainable long-term cost structure and viable CCOs? And I think you can answer those two questions differently, right? The challenge has been, what do you do in the fourth quarter of a year with a rate setting process that we're getting ready, that we're on the very verge of rolling out, that's reasonable and fair? When we met with the governor, I think put it really well to say, it's like going to 15 CCOs and saying this is a fair, equitable process that the federal government has signed off on and has been reviewed by outside bodies, and we're going to use it for you, but come up with something different for another CCO. Beyond that, it starts getting, it really does get into kind of the actuarial issues that I think we've talked with almost all of you at length, trying to help simplify it, and there's not a super simple answer. Laura, you want to comment, speak to that?
Sure. I think I can provide a little bit of color, and certainly we can also follow up with a little bit more information too that might be helpful in illustrating this. And so, I think in addition to everything Pat said about generally like the methodology and the process and the work that we did to review it and understand it to make sure that, we were comfortable with it as well after we arrived, I think it's really also important to look at the rates themselves and understand, not just how they're developed, but what the end result is. And so at a high level, we develop rates on a regional basis. And so we have 4 regions across the state. One of those regions is the Tri-County area. And in that region, we have 2 CCOs, FamilyCare and HealthShare. And what we do is we pool the claims and encounter data for those 2 CCOs all together, and we develop a regional rate. And then the only differences between that I guess the regional rate is only differentiated for the 2 CCOs based on the relative risk of the populations they serve. And there are also some small, additional, we call them add-ons, but they're small kind of cost-based additional costs that are based on each CCO's financials that we add on to that. And when we've reported about the rates that we pay to CCOs, what you usually see is one rate for every CCO. And what that is it's a weighted average. It's a rate where we take the members and all the different categories of membership that people can be eligible for Medicaid, and you take the rate that applies to those categories, and we multiply them all together and then divide out by the total number of members and give you an average. So what happens is that you're not really seeing that for similar categories of people, how are the rates comparing for HealthShare versus FamilyCare? And when you look category by category, what you see is the rates are extremely similar between the two because of that regional rate methodology that I just described. And the differences within a rate category really are reflecting the differences in the risk, basically the health status of the population that each of those CCOs is serving in that category. I know that's kind of a technical kind of description, but we can send you just a quick table that actually shows that differentiation. And I think that's really important to note, that you need to go deeper than a weighted average, which is going to reflect, whether one CCO has more or less members that are compensated at a higher rate because they're more or less risky.